Meet Marcus, 59 years old, and moments ago he collapsed, clutching his head with what he called the worst headache of his life. Then he vomited, and now he is going downhill fast, barely responsive, opening his eyes only to pain. His blood pressure is 210/110. His heart rate is only 48. His breathing has gone irregular, and his left pupil is blown wide and sluggish. This is not the stroke from our last case. This is a bleed, with the pressure inside his skull climbing toward catastrophe. And the clot-dissolving drug that would have saved a clot? Here, it would kill him. 1 patient. 6 decisions. Let's take them. Step 1. Recognize the cues. Start in the nurse's notes and read the story of how fast this came on. A sudden, explosive headache, the worst of his life. Vomiting. A level of consciousness that is dropping by the minute. This is not the gradual, painless weakness of a clot. This is something violent and rising. So move through every tab, the vitals, the labs, the orders, the history, and gather the cues that tell you 2 things. That this is a bleed, and that the pressure in his head is dangerously high. Open the vital signs tab and read them as a pattern, because together they spell one thing. His blood pressure is 210/110, sky high, with a wide gap between the numbers. His heart rate is only 48, slow, and his breathing is irregular. That triad, a rising pressure, a slowing heart, and irregular breathing, is the Cushing triad, a late and ominous sign that the pressure inside the skull is dangerously high. Add a falling level of consciousness and a left pupil that is blown and fixed, and you are watching the brain begin to herniate. Now the labs and imaging tab, and here is the finding that flips everything from the last case. The non-contrast CT scan shows blood, an intracerebral hemorrhage, confirmed. Remember the stroke patient before him, whose scan had to rule out a bleed before the clot-dissolving drug? This is that bleed. His clotting studies are normal, so this is not from a blood thinner. It is the pressure of long-standing hypertension. And that single line, hemorrhage confirmed, is why the clot-buster here is not just wrong, it is lethal. Now the orders tab, and every line is aimed at the pressure inside his skull. Head of bed elevated to 30 degrees, head kept midline to let blood drain out of the head. Airway protection and oxygen, because a falling level of consciousness cannot protect the airway, and low oxygen or high carbon dioxide would drive the pressure even higher. A titratable drip to bring the blood pressure down, carefully. An urgent neurosurgery consult. And, in bold, no thrombolytics, no antiplatelets, no anticoagulants. The orders are a checklist for lowering intracranial pressure. Finally, the history tab. He has long-standing, poorly controlled high blood pressure, the most common cause of this kind of deep brain bleed. He takes no blood thinners, which tells you the hemorrhage is from pressure, not from a medication you would need to reverse. He is a smoker. And it began suddenly, at rest, about 30 minutes ago. The history points straight at a hypertensive hemorrhage, and the clock on the brain tissue and on herniation is already running. Here are the cues that count. First, the onset, a sudden thunderclap headache with vomiting and a fast-dropping level of consciousness. The signature of a bleed, not a clot. Second, the Cushing triad, a blood pressure of 210/110, a heart rate of 48, and irregular breathing, the late warning of high intracranial pressure. Third, the herniation signs, a blown left pupil and a falling score. And fourth, the confirmation, blood on the CT scan. Put them together, a hemorrhagic stroke with rising pressure and early herniation. And the loudest lesson of all, here, a clot-buster kills. Step 2. Analyze the cues. The single most important call you make in a stroke is the one this step forces. Is it a clot or a bleed? Because the treatments are opposites, and getting it wrong is fatal. So take each finding and sort it. Which of these would point toward an ordinary ischemic clot, the kind you might thrombolize? And which scream hemorrhage with rising pressure? The answer is not subtle here, and it decides whether the clot-dissolving drug is a cure or a weapon. Sort them, and the picture is unmistakable. A gradual, painless deficit would suggest a clot. But everything here points the other way. A sudden, explosive headache and vomiting are hallmarks of a bleed. The Cushing triad, high pressure, slow heart, irregular breathing, is rising intracranial pressure. A blown pupil and a dropping level of consciousness are herniation. And blood on the CT scan confirms it. This is a hemorrhagic stroke with dangerously high pressure inside the skull. That means the clot-dissolving drug is absolutely contraindicated, and the whole plan shifts to bringing that pressure down. Step 3. Prioritize. Name the one problem and the first action. And feel the wrong turns waiting. One instinct, primed by the last case, is to reach for the clot-dissolving drug. This is a stroke, after all. Another sees the blood pressure of 210/110 and wants to crash it down to normal. A third wants to lay him flat and pour in fluids to support him. Each of those, here, harms or kills. So ask, what is the immediate threat to his life, and what first action addresses it without driving the pressure higher? The priority is the rising intracranial pressure and impending herniation, and the first actions are to protect the airway and lower that pressure, not to give any drug that thins the blood. Here is why. The blown pupil and falling consciousness mean the brain is being squeezed and beginning to herniate. That is what kills in the next minutes. So you secure the airway and oxygenation, raise the head of the bed to 30 degrees with the head midline, and begin controlled blood pressure reduction, while neurosurgery mobilizes. You do not give the clot-buster, which would turn a bleed into a fatal one. You do not slam the pressure to normal, which would starve the brain of perfusion. And you never lay him flat, which would raise the pressure further. Step 4. Generate the solutions. Lay out everything that belongs in the plan. This is select all that apply. Think, lower the pressure in the skull, and stop the bleed from getting worse. Position him to drain the head. So, head of bed to 30 degrees, head midline. Protect the airway and oxygenate, avoiding the low oxygen or high carbon dioxide that spike pressure. Bring the blood pressure down carefully. With a titratable agent, get neurosurgery now, and check the neuro exam often. And for active herniation, osmotic therapy, mannitol or hypertonic saline. Then the traps, the clot-dissolving drug, and laying him flat. Gather what lowers the pressure, refuse what raises it. Here is the plan. Elevate the head of the bed to about 30 degrees, and keep the head midline and neutral. No neck flexion, no tight collar, to let venous blood drain and lower the pressure. Protect the airway and give oxygen, keeping carbon dioxide normal, because both low oxygen and high carbon dioxide raise intracranial pressure. Lower the blood pressure with a titratable drip like nicardipine, carefully, toward the target. Not to the floor, so you still perfuse the brain. Get an emergent neurosurgery consult and do frequent neurochecks, pupils and level of consciousness. And give osmotic therapy, mannitol or hypertonic saline, if he is herniating. The traps are lethal here. A thrombolytic would expand the bleed, and lying flat would raise the pressure. Neither belongs. Step 5. Take action. And the order follows the airway, the head, and the pressure. First, the airway, because a patient this obtunded cannot protect it, and oxygenation guards the brain. Then, position. To start draining the pressure immediately, and for free. Then, the blood pressure. Brought down with control, not violence. And then, the definitive path, neurosurgery, imaging already in hand, and measures for herniation. Sequence these the way you would move through the room, always asking, is anything I am doing raising the pressure in his head? Here is the order. First, protect the airway and oxygenate. A falling level of consciousness and a blown pupil mean he may need a definitive airway, and hypoxia would worsen everything. Second, elevate the head of the bed to 30 degrees and keep the head midline. This lowers intracranial pressure right away, at no cost. Third, begin controlled blood pressure reduction with a titratable agent, toward the guideline target, preserving perfusion. And fourth, mobilize neurosurgery with the confirming CT, reverse any coagulopathy and give osmotic therapy for herniation, with frequent neurochecks throughout. Airway, position, pressure, neurosurgery. And through all of it, no clot-buster, and never flat. Step 6. Evaluate. You have protected the airway, positioned him, started lowering the pressure, and called neurosurgery. Now close the loop, because in a rising pressure brain, the exam changes minute to minute. So reassess. Is that blown pupil starting to react again? Is his level of consciousness climbing back? Is the blood pressure coming under control and the Cushing pattern easing? Or is the pupil fixing, the score falling further, the brain herniating despite you? Ask the exam directly, is the pressure coming down, or is he herniating? Here is the reassessment, and it cuts two ways. The hopeful path. With the head up, the airway secure, and the pressure controlled, his blood pressure settles toward the 150s, the Cushing pattern eases, his pupil begins to react, and his level of consciousness ticks up, signs the pressure is coming down. But watch for the other path. If that pupil fixes and dilates further, if his score keeps dropping, he is herniating, and you escalate at once, osmotic therapy and emergent neurosurgery, a drain or an evacuation, because the skull cannot give and something must. The evaluation names the next move either way. And notice what never appeared in this entire case, a clot-dissolving drug. That was the whole point. Let's tie the case together. Your cues: a sudden thunderclap headache with vomiting and a dropping level of consciousness, a Cushing triad of a blood pressure of 210/110, a heart rate of 48 and irregular breathing, a blown left pupil and blood confirmed on the CT scan. Your action: treat it as a hemorrhagic stroke with rising intracranial pressure, protect the airway and oxygenate, elevate the head of the bed to 30 degrees with the head midline, lower the blood pressure with control, mobilize neurosurgery and give osmotic therapy for herniation, and never ever a clot-buster. And the outcomes you are steering toward: the pressure lowered, herniation averted, the bleed in the surgeon's hands, and no fatal thrombolytic given. Recognize, analyze, prioritize, generate, act, evaluate. A clot and a bleed look alike for a moment. The headache, the Cushing triad, and the scan tell them apart. And here it is. The whole case on one screen. The cues, the 6 steps, the rule that separates a bleed from a clot, and the numbers that mattered. Screenshot this now, and you carry the entire case in your pocket. Then let's meet the next patient. Now, the next patient. A young man on the floor, seizing, and he has been seizing for more than 5 minutes without stopping. His jaw is clenched, his lips are turning blue, no air is moving. Here is the hard fact. After 5 minutes, a seizure will not reliably stop on its own, and every second steals oxygen from the brain. 2 moves decide everything, and the order matters. 6 decisions. That is case 211.